Thank you very much, Doug. The Primary Care Committee is functioning in parallel with all the other committees. Our work is slightly separate from the main committees and will continue after the Rome 4 outputs have been formally declared. This is the representation of our committee. In addition to the people listed here, we have access to a number of colleagues in different countries, and we've had some informal support from the European Society of Primary Care Gastroenterology. Just by way of background, in most countries, and so that for that I'll include Europe, particularly the United Kingdom and Canada, 95%, and in the UK and in Canada 100% of initial contact between the patient and the physician is in primary care. I think that's quite important. In the United States, that proportion is going up. And the presenting symptoms, the way they are categorized and described, and the way they are framed is done mostly in primary care in many countries in the world. So the role of primary care cannot be underestimated when it comes to the functional GI disorders. It's the very first point of contact, and in fact, more importantly than that, it's the first point of interpretation and, as I said, framing. It's important, therefore, that the work of the Rome 4 collective is properly translated or interfaced with primary care so that the learnings and the various recommendations that are made can be carried through to the kind of people who are going to have to deal with people at the first point of contact. The committee has been working for the last 18 months to 2 years in a completely virtual fashion. In fact, our first physical meeting is tomorrow morning when about 3/4 of the committee members are able to be present. But we've made reasonable progress. The first of our outputs is a manuscript on the perceptions, diagnosis and management of IBS in primary care. We felt that it was important to find out what was known about the management and diagnosis of primary care, of IBS in primary care. As you can imagine, this has been a very difficult piece of work. There have been relatively few publications relating to primary care since the Rome 3 working group produced its report. A lot of the data that we had access to was relatively old. But we have discovered a number of important points about the way primary care clinicians think from various countries all around the world. And I have to say that we discovered a fairly significant dissonance between, I think, the advice given by many of our specialist colleagues and the way primary care clinicians work. I'm pleased to say that this particular output, which was submitted recently to a journal, has been invited back for representation to the journal pending a certain number of editorial and material changes. We will do that over the next few weeks and seek the assistance of the Rome committee to see if the alterations which have been suggested will be found satisfactory. Following on from that, the fact that not everybody in primary care immediately recognized the existence of any definitive criteria, and furthermore there was a general reluctance on the part of many clinicians to make a positive diagnosis. It became clear that one of the stumbling blocks to diagnosing IBS was the lack of an explanatory model. An explanatory model is a kind of a mental pictorial of what a condition happens to be. And the example that I normally use is that if, for example, you're trying to explain to a patient that the patient has heart failure, you can visualize the heart not pumping properly, and as a consequence you can visualize the collection of fluid in the ankles and in the lungs, and it's a picture that you can transmit to the patient and something that the patient can understand. There seems to be some evidence that the explanatory models that we have in our heads as clinicians are not incredibly clear, and they're often at great variance with the models that patients have in their minds. So as a consequence of the first piece of work, we've actually commissioned a second discussion review, an interesting kind of description of a paper where we are looking at the kind of explanatory models that exist and what might be used by clinicians in terms of communication with their patients. And I think that that's going to be an important step in terms of not just embedding the concept of the functional GI disorders into the minds of primary care physicians, well, I suppose clinicians everywhere, all sorts of clinicians, but also in terms of trying to make primary care physicians think of IBS and other functional GI disorders in a more positive way, something to be diagnosed with a specific degree of confidence rather than as a descriptive entity, as, for example, happens with constipation as opposed to IBS-C. Following that, and in parallel with that work, the manuscript, by the way, is about 90% done. We're now finishing off the edges, and we hope to have it submitted to a journal sometime in the next 2 or 3 months. The third of our jobs, which we set out to do, was to conduct a rather more definitive survey of primary care physicians, mainly in Europe and also in the US and in Canada, on how they actually perceive and diagnose IBS, and the level of confidence with which they either make the diagnosis or indeed receive the diagnosis from a fellow clinician, say a secondary care clinician. And this will be an important piece of work. We're about halfway along now, and we hope to have that manuscript ready sometime later this year. A fourth item that we're planning is a handbook, and I've brought an example of the kind of thing we're after, something about ½ an inch thick and about half the size of a legal pad, something that's going to be accessible for primary care physicians, something that can sit on the desk and be easily picked up and used, something that can be easily distributed, perhaps distributed via industry, via representatives, or as something that provides an interface between the clinician and the pharmaceutical industry, and also through educational channels. We hope to create the book in such a way that this will link in with the existing electronic repositories which you are hoping to create, so that people looking for greater detail will be able to go to the appropriate website and get further. Again, I need to contextualize the fact that primary care physicians have a lot more than gastroenterology on their hands. GI work is somewhat 5 to 10% of our workload. And the rest of it consists, in fact, of everything from sort of crying babies to dementia. So it must never be assumed that we have nothing else to think about apart from GI problems. Indeed, I've heard it said that whereas primary care physicians are not specialists in the sense of gastroenterologists, we are certainly experts in the way that we have to deal with our patients. And we are all too well aware, therefore, of the connectivity between one kind of problem and another. Of course, any work that involves primary care in conjunction with secondary care has its challenges. And I mentioned some of the dissonant areas which exist, although I'm getting the impression that the newer thinking in the Rome 4 process is much more clinical friendly, and I think will be more accessible to clinicians everywhere, including in primary care. But of course, there are huge variations in between different countries in the way healthcare is delivered, and this has an important impact on how IBS and the other functional GI disorders are diagnosed and managed. And finally, I'm pleased to say that we may be able to play a role in terms of either informal or some other form of input into some other aspects of the Rome work, including things like functional dyspepsia and so forth. I think for primary care to be working entirely in isolation in its own committee is probably just slightly selling short the total product. So that's just a little plea. Thank you.